Are we live? Is this live already? I don't know. Is it? YouTube says it is. Hi everyone. So it's a few minutes past 2 in Brazil. My name is Galvani. I am in between shifts. I have worked this morning reporting exams from the office, and in the afternoon I report CT scans and MRIs from home. So I thought, what if I stream a CT scan online on YouTube? Maybe I have an audience. Maybe someone in chat might be interested. So I guess this is not the case today because this is the first stream of the channel, and as you have may notice, I'm struggling to speak English. This is not my, of course, not my first language. So please bear with me. I also had a really short night of sleep. I'm kind of sleepy and tired, so but if I don't stream today, I guess I won't start streaming anytime soon. So I gotta push it and keep going forward. So I have this abdominal CT scan. So it's a classic. It's a pretty common case. Everyone should be aware of this kind of diagnosis. It's quite easy if you know what you're looking for. So this is a young female patient. Let me just put it on screen. This is it. This is a case from my routine. I reported it a few days ago myself, and this was a pretty common case of right-sided abdominal pain on the emergency. So it's a young female. This is a CT scan. This is the original images. Of course, it is a axial section of the body. It's comprised of 476 images, axial sections of the abdomen from the bases of the lungs to the pelvic floor. So this is an abdominal CT. It's both superior abdomen and pelvis. So this is an unenhanced CT scan because reasons I don't know. Every single, as you may know, every single acute abdomen of unknown origin in a ER situation must be done with contrast, with intravenous contrast, must be in an enhanced CT scan because some disease just won't show up. So you are at risk of returning a report as normal, and the patient could be severely ill and you just missed the diagnosis. So this is a mistake by itself, but in this case we did manage to make the correct diagnosis without the need to use intravenous contrast. So let's begin. So as I said, this is the axial section of the body. This is an axial view. We could do a multiplanar reconstruction just by hitting a button, and this would lead us to two other planes of view, two other sections called the sagittal view, like this one. This is the sagittal view. This is the spine from top to bottom, from head up there to the toes down there. This is front. This is the umbilicus, the navel. And this is the buttocks, the lumbar region. This is the axial. As I roll down the images, you can follow here that we are going from top. These are breasts implants. This looks like hollow, but it's actually outside of the window. This is actually the lungs. See, these are the lungs. Let me get to the correct window, the soft tissue window. And we can also do a coronal multiplanar reconstruction, MPR. So this is coronal, this is from front to back. This is the navel. And this is the lumbar region and the buttocks. So this is the spine on an axial, transverse axial view, and this is the spine on the coronal view. But we are here actually to look for a cause of a right-sided abdominal pain that won't go away, and it's been like that for over 24 hours. So this is an acute abdomen of a young female. So let's roll. Let's roll from the base of the lungs to the pelvic floor. On the right, you see the liver. This massive soft tissue mass isn't a mass, it's the largest abdominal cavity organ. This spot right here is the gallbladder, which is normal. Also the liver is normal. This is the spleen on the opposite side. As you may know or may not know, we look at the patient as if she was lying on her back and we were seated by her feet. So we do an axial cut and look at the cut, knowing that the slice, we do a slice and look at the slice, knowing that this is the left side, this is the right side, this is front, and this is back. So in a normal individual, this should be the liver, this should be the spleen. Between the left liver lobe and the spleen, there is the stomach. And this is the pancreas. These are the retroperitoneal vessels and a bunch of other stuff. And to this side is the right-sided kidney, and this is the left kidney. So I'm going like this because the camera is kind of in front of my screen. So we have a right-sided pain. I'll go to the pelvis and I can see the uterus, the rectum, and the anal margin. So also the bladder, the urinary bladder is right here. It's partially filled with urine. So we also have colon and bowel. This is all bowel. Bowel usually doesn't have this much air in it, but it's okay to have that. And I can tell that this patient has undergone plastic surgery, some kind of liposuction, because there is scarring on the superficial fat tissue. She is kind of chubby, and I'm saying that because we usually compare this normal fat to the normal intracavitary and extraperitoneal fat. So fat here must resemble fat here to be okay. When there is a inflammatory disease or a neoplastic disease or some kind of disease, usually the abdominal fat gets stranded, gets densified, gets hyperattenuated. I guess. Is that a word? It gets denser. It gets denser. It gets from this kind of dark gray to closer to this kind of light gray. So it's densified. It's denser. It's stranded. So this is quite what we are looking for in this scan. So it's a right-sided flank pain for over 24 hours. Of course, the most common disease we must look for, no matter what is written on the exam request, is appendicitis. We must be sure that the patient doesn't have signs of acute appendicitis, because we know acute appendicitis, if it's left untreated for over 24 or 48 hours, it can be lethal. It may kill the patient. So most of the time, if you miss an appendicitis, the patient is going to suffer. So how do you find the appendix? It's quite easy. I guess some of you may have already noticed. So you roll down to the right flank or to the right iliac fossa. Look for the right column and follow it, rolling the images until it ends. So when the right column ends right here, this is the second base, the base of the second, the first portion of the large colon. So the large bowel, the colon, is the second. So the ileus ends in the ileocecal valve, which is the transition from ileus to secum, and right below to this direction, we should see the start of the appendix. So the appendix starts right below, just below the ileocecal valve. So I look for the second. I find the ileocecal valve, which is this feature right here, and I roll down the images until I find the appendix. So this is the appendix. So I can see here that the second wall is thickened. It's hypodense, and hypoattenuating, and I can see here that there is anomalous content inside the base of the appendix, which call it. It's a stone made of pieces, and this is the cause of the obstruction, which leads to the inflammation of the appendix. So what are the features of the appendix? In cases, we can call it a acute appendicitis. What should I look for to make that diagnosis? So first of all, I must find the appendix and be sure it is the appendix. So this is the appendix. It's a elongated structure that starts from the bottom, from the bottom of the second. It can go anywhere. It usually, about 50% of times, it's posterior to the second, and it ends in the blind end. It just ends just like this. We can see that much easily on the coronal view. This is the appendix right here, and then it ends right here. So we have the appendix, we have thickening of the secum right where it should be, and right where, just where the patient feels discomfort. This is the right-sided pain the patient was complaining about. So the next step to make this diagnosis is to measure how big the appendix is on a transversal view. So this is this little circle right here is the appendix in a transverse view, sliced like we are slicing the entire body. So I'm going to, this is a longitudinal image view of the appendix, and this is a axial transversal view of the appendix. So now I'm going to measure it from side to side, and it's measuring 12 millimeters. So 12 millimeters is about twice the size it should be. So if I see a appendix with less than 7 millimeters, I can't really say it's inflamed. This is the most important feature it must have. It must be over 7 or 8 millimeters in transverse diameter. I also have here the anomalous content on its base, which is the fecalids or the appendiculids right here. This is the cause of the obstruction. And the second most important feature is the stranging of the fat all around the appendix. So, as you may have noticed, this is a normal fat. It looks like this. And this is stranded fat, edematous fat. This is inflammatory, inflamed fat. So this fat tells us the appendix is inflamed. So this is an acute appendicitis in a young female patient with right-sided pain. So this is a classic. There are a few other things we should look for in this case. We should look for free air, free intra-abdominal air. So we hit the lung window to make it all black and white. I don't know where it is. Right here. So, and we roll the images from down to up, from cranial to caudal, and look for free air. See, there is air inside the appendix, on the bowel, and inside the colon, but there is no free air. So this is a sign that the appendix may not be ruptured. Also, we must get back to the soft tissue window. I just hit 4 on my keyboard in Wheezes to get it to soft tissue window, and we must look for fluid collections close by to the appendix, which are usually abscesses, which are pus, which are inflammatory collections of inflammatory fluid, feces, and all that stuff, which makes the surgery even harder, even more complicated in long-standing cases of appendicitis. So this is it. We have the fat stranding, but we have no signs of fluid collections or free air. Pneumoperitoneum is the terminology to call free air inside the abdominal cavity. So we have no signs of complicated appendicitis. This is a common, a regular, and easy to diagnose on CT scan appendicitis of a young female. So this is it. Oh, hello Tim, what's up, mate? Oh, is this working? Yep, acute appendicitis, it is. This is quite a common and easy case for you, I guess. We have discussed it many times, haven't we? So it's been a while already. How long are we on? We are 20 minutes on. I guess this is it. this is it for today. If you enjoyed this live stream, if you learned something, just anything really, just leave a comment below, like and subscribe, and I'll be sure to be around many times a week. I'm planning on streaming almost every day from Monday to Saturday, bringing you guys these kinds of exams. I have already collected, I guess, 30, 28, 32 cases just to live stream here on YouTube. So share, comment, like and subscribe, just that, so it can help this channel grow. And thank you so much for tuning in, and we'll see each other. I'll see you guys next time. Bye bye.